Bienvenue à toutes et à tous pour ce premier colloque du DESS de l'année 2022. J'espère que vous avez bien commencé l'année sur une note positive, mais plutôt sans des résultats de tests positifs. Et j'ai le plaisir de modérer en fait ce premier colloque. Je m'appelle, pour ceux qui ne me connaissent pas, Eric von Helm. Je suis médecin de santé publique épidémiologiste et dirige le groupe Cochrane Suisse. Et j'ai le plaisir de présenter l'intervenante. C'est Cornelia Barth, qui va nous présenter en anglais. Et pour cette raison, donc sa présentation en anglais, pour cette raison, je change déjà pour l'introduction en anglais. Cornelia works with us since the last year, and she joined our team, Unisanté at the department, and our team as the coordinator of Cochrane Switzerland. But she will not talk about Cochrane and related things today. And the reason why is that she's also managing actually her separate own research project, which actually has received funding from the Swedish Research Council and is a truly international project. The name of that project is the acronym is GRACE, and that stands for Gender Aspects in Rehabilitation of Persons with Amputation in Conflict-Affected Environments. But she will not only talk about that project, but more broadly about physical rehabilitation in contexts of fragile health systems. Nell is a physiotherapist by training, but she has spent actually the last 13 years or so in humanitarian services, and in particular with the International Red Cross, and has worked in contexts of great diversity and complexity. And her expertise is in actually developing rehabilitation services in these contexts of fragile health systems, and in particular in countries of conflict, and where obviously resources for medical care, but even more for rehabilitation are very scarce. So with that, happy to have you on that first colloquium, and over to you now.
Thank you very much, Eric. I hope you can all hear me and see the slide. I have nothing else to say. Eric has said it all, but thank you again also to Unisanté for giving me this floor, for allowing me to do it in English, my research language, and also for hosting me for that position. And now we will get right into it. So Eric also talked about what the presentation is and to give you a bit more of an insight, we'll start with a background to I'll explain how we came to do this research and present also the research we've done to date. And finally, we'll get to the GRACE project, which is the position that I'm hosted here at Unisanté for. So let's start. If you see these pictures here on the slides, what do they have in common? So they show women with disabilities in contexts that we label as low resources, conflict affected, contexts of fragile health systems. And when I was working for the International Committee of the Red Cross as a rehabilitation specialist, most of our patients were men. In the annual reports, these figures usually appeared like that. So these are screenshots from the annual reports. Children were not even sex disaggregated, and women were mentioned as if they were a subgroup among our target population. The norm was the adult male patient. And I was told that men are the ones who are exposed to violence and injury, and they are thus at a greater risk of ending up disabled in countries of conflict. So this was the assumption on which also the rehabilitation program of the Icsc was based, and which explains the figures of low female attendance. The explanation made sense, but still I had a feeling that there was an untold story, and this was the beginning of our research. The reality nowadays is that warfare looks a lot more like this, more than the pictures beforehand. And that means indiscriminate attacks in dense urban settings, ever increasing numbers of displacement, complex, volatile, long-lasting conflicts. Now, it is very difficult to get hold of reliable published figures on incidence and prevalence of conditions leading to physical disability in extreme environments. But when connecting the dots, one can conclude that conditions requiring rehabilitation are to a great extent the result of fragile or collapsed health systems, most probably more than disabilities caused by direct exposure to war-related violence. Why is that? Because war-related violence, despite its traumatizing impact, remains relatively scattered, whereas fragile health systems are a massive public health problem. Such health systems suffer from an absence of healthcare, which drives people, if they survive, directly into disability. And that can be clubfoot, polio, cerebral palsy, or diabetes, because diabetes management is not the priority of collapsing health systems in crisis settings. And the result of uncontrolled diabetes is often this: a permanent disability that requires labor and cost-intensive, lengthy rehabilitation, and lifelong prosthetic fitting. Now, with regards to the gender question, it's well documented that the prevalence of disability is higher in females compared to males worldwide. And most of them live in low middle income countries. So there are many reasons for that. Some are more sex related and some are more gender related, or a mix of both. First of all, women have a higher life expectancy, and we know that the probability to acquire disability rises with age. And there are also certain risks associated with childbirth that can lead to disability. So is this sex related or gender related? Because we also know, and that has been shown in numerous gender studies, that women face significantly more obstacles in accessing healthcare in general. And then there are other reasons like poor workforce conditions and, of course, gender-based violence. So up to here, this is what we know. Now, my objective was to test if the predominantly male population among our rehabilitation users accessing ICRC centers, if this reflected the real sex distribution of rehabilitation needs in these settings, or if there were hints on access issues for women and girls. And after having worked in such settings for years, there was a lot I could think of. I have witnessed how women and girls with and without disabilities were viewed, how they viewed themselves, how they were treated, and how they behaved. But in order to find out, I needed access to data that were more detailed than the annual reports. And a few words now about the ICRC's physical rehabilitation program through which I was able to access data. The ICRC runs and supports around 150 rehabilitation projects worldwide. And together with local partners, the ICRC is very involved in improving access, quality, and sustainability of rehabilitation services, inclusion of persons with disabilities, and the development of rehabilitation workforce. And with its support, close to 500,000 persons with disabilities receive rehab services each year. The Icsc has also developed an electronic database that was donated to supported rehab centers. And this database is nothing compared to health information systems in high-income countries, but it is the only information available from conflict-affected countries. So here you have a QR code leading to the full text of our study that was published in the WHO bulletin. And you see also the countries. So the data originate from very challenging settings that includes places where the Icsc didn't even have access for periods of time, for instance, Somalia. So you have to instruct people you never met remotely with their challenging infrastructure, old computers, network and electricity cuts, how to extract an Excel sheet and send it to you. And they obviously also have other worries than extracting that Excel sheet. So data mining was an adventure. That's all I can say. This data, these are not registries as we know them from rich countries. So any attempt for a routine collection may be compromised by issues of infrastructure, staff, priorities, then of course the conflict, but also the understanding of the value of correctly collecting data. So anyway, we ended up having data from 14 countries and over 280,000 individual patient files over a 30 years time range. And we ended up looking at the most robust variables, which we trusted. And also because the study describes an entirely unknown population. So this is really a broad overview. And now for the colloquium, we'll mainly look at sex and gender. We found lower female representation across countries, with remarkable differences between, but across all of the studied countries, across age groups, and across conditions. This included conditions that could not be directly attributed to combat. An example here is the post-polio syndrome, not acquired during combat. And here we have a 34% female representation at rehabilitation. And there's published data from various countries that show that the actual prevalence is the reverse. There's a significantly higher prevalence among females than among males. And the same applies to age. We had deliberately separated the population into meaningful age groups. And we considered it unlikely that the overrepresentation of under 5-year-old boys compared to girls is explained by combat-related disability. And also in the group of over 60-year-olds, you should actually see more women than men requiring rehabilitation because of higher life expectancy. So it's difficult to find an explanation for only 30% women other than with access barriers of whichever kind. Now, in terms of reasons for rehabilitation attendance, the biggest cohort were persons with amputations. And this was the group we chose to investigate further in a subsequent study. And we'll get there later on. However, in order to answer the main questions that our first study raised, we would have needed to go on site and systematically talk to involved persons, women, men with disabilities, family members, rehab providers, and community leaders, decision makers. And we applied for funding, but were turned down because research grants for such projects are very rare. So as we keep applying and wait for money to come in, let's take an excursion through some background information. Let's have a look at fragile health systems and its relation to physical rehabilitation and disability and gender. So there are persons needing and using rehabilitation services, and there are those who provide them. And they don't live in a vacuum, but in a network of contexts and systems. So in order to understand the rehabilitation sector in such countries, we need to take into account the world in which these persons operate, and that defines both users and providers. So we will now look at aspects which make up a rehabilitation sector in the fragile health systems of conflict-affected contexts. Let's start with context. Context impacts on all other elements. It defines the population, their health conditions and disabilities, their demographics. It defines the services that are provided for these populations, and it defines the systems, which stands for health and other systems. Systems define the services that are provided and the populations that are served. And services, which means rehabilitation care, infrastructure, and the workforce, as well as the population, so the persons in need of services, they also influence each other. Now, context in more detail, let's define conflict-affected first. Most conflict nowadays are protracted crises. So acute conflict going into post-war, into a post-war phase directly, that actually doesn't exist anymore. We rather see acute phases of conflict interchanging with ceasefire and some stability within a protracted crisis. And there's no end in sight. There's many, many examples of currently worldwide: South Sudan, Afghanistan, Somalia, Libya, Yemen. The list is very long. And then there are also countries that have a context, a defined context of protracted crisis on their territory, or even across countries. An example is the Kashmir conflict that involves India and Pakistan, which are both countries that are not, most of the countries as low resources, but not conflict affected as such. But this context drags the country into, or affects the country conflict-wise. Another context are so-called frozen conflicts, like Western Sahara, with a population living on Algerian ground in a state of limbo, refugees for generations, entirely dependent on foreign aid. And many of these conflict-affected contexts are part of our research. Then we have countries that experience disasters, often exacerbated by climate change. This does not fall under the ICRC's mandate, but such situations can cause or intensify armed conflict. And we see that more and more, especially with climate change. Now, both scenarios, disasters or war, usually drag surrounding countries and entire regions into a vicious circle. So even the not directly affected countries, they get their share by the influx of refugee populations. So the neighboring countries at peace or contexts in countries are also conflict affected. Bangladesh with a Rohingya population, Lebanon with the Syrian refugees. And then additional contexts are post-war, Cambodia, for instance, and they are also very clearly still conflict affected, only by the massive landmine contamination decades after ceasefire. And then as a last one, we have low resource contexts that live in a state of threat of being dragged into a conflict. An example is Togo and the other countries on the West African coast, which are threatened by Islamic troops from the north. So also part of the country's energy, we can say, goes into preparation for a conflict. Then we also have a number of scenarios that characterize these contexts, and all of these scenarios, the impact on population health and on rehabilitation needs, as well as services. We also have the concept of, let's say, culture within such contexts. For instance, how does identity function within societies? What about the perception of disability, stigma? And here's also the gender question rooted. And another layer within culture is, for instance, how are the ideas of active rehabilitation or of independence perceived, which are so important for us and for how rehab was developed in the rich countries. Now, to come back to our model, we understand better now how context can impact on everything else. And now let's have a look at systems. So there are governmental systems. They are usually fragmented to the point even that the WHO model of the 6 building blocks on health systems almost looks like wishful thinking. Also because you cannot pick health systems only when, for instance, primary education is so weak that it is difficult to build a professional rehabilitation workforce, or when job chances on the market are so limited that the talented workforce quit the country. And then there are other systems that usually support, sustain, substitute, but also supersede these dysfunctional state systems, and not always and only for the better. There are the powerful international organizations, often with their own agenda. Then we have systems that are sustained by communities, by clans, families, by the church, by traditional healers, by persons who share a common story, disability, gender. And then there's the whole parallel world of private actors. So it's quite complex to say fragile health systems. That actually means not much more than just thinking of health systems. Now, what does that mean for rehabilitation? The needs for rehabilitation in conflict-affected countries will be increased, urgent, and complex. The clinical representations requiring rehabilitation will be pre-existing conditions that were deteriorating or further developing, plus a variety of physical and psychological trauma accumulated at different points in time. Poorly contained epidemics, communicable diseases, where rehab needs are actually often overlooked. Now with long COVID, the awareness of the importance of rehab is getting better. And then we have the big burden of NCDs, non-communicable diseases, exacerbated in conflict because barely managed. And NCDs also make up current and future global health challenges that concern conflict-affected countries just the same. Sedentary lifestyle, unhealthy diets, lack of physical activity, mental health problems, aging populations. The most urgent health challenges of the present and the future, they cannot be contained without adequate rehabilitation. And also to link population with context. The cultural concepts and beliefs around disability may be stigmatizing. The most vulnerable will get further marginalized, exploited, exposed. And also persons in need of rehabilitation may have faced forced displacement and separation from their families. They may live in unfamiliar, unsafe households. So all of this does not only challenge service provision, but as you can imagine, it also complicates research in these settings. Now, if we look at population characteristics, in our research, we provided a snapshot of clinical pictures of age and sex and some other factors. And this relates to persons attending rehabilitation. There's a number of aspects about these persons that we don't know for sure, because the database proved unreliable or incomplete, and we didn't publish our analysis to this regard. The main limitation, though, of our research to date is that these groups are not representative, because we do not have representative data from extreme environments. So these are the people that are reaching rehabilitation care. We have no data from the non-attendees, and we know that the needs are much greater than what we see in the rehab centers. We also know that not only the supply is low, but also the demand, because there's not enough awareness besides other issues. And now for the last group, we'll come to the rehabilitation services. So here's a QR code of our qualitative study with over 30 physiotherapists from 18 conflict-affected countries. And the topic was barriers and facilitators to developing rehab services in their countries. And the list you can see here is what participants described as lacking and thus impeding the development of rehabilitation services. Here is what rehabilitation services should look like. So let's say the minimum setup of a team. Research has shown that for complex conditions, multidisciplinary rehabilitation is effective. It cannot be done by one profession in series with others. It has to be in a multidisciplinary approach. The reality is actually that in most settings, rehabilitation is covered by one group from this graph, which is the physiotherapists, who carry a big burden on their shoulders. And here you have a quote from one participant from Asia who says, right now we do not have any occupational therapists, we do not have speech therapists. So the physiotherapy in our country is doing all the job of the OT and ST, occupational and speech therapist. So this was our excursion into the world of physical rehabilitation in fragile health systems and rehabilitation needs. And you see there's a lot to be done. It will never get boring. But now it's about time, because meanwhile, let's say in our, after our excursion, meanwhile, a grant came in for our unanswered question about access barriers for women and girls in such settings. So now we'll get to our GRACE project, and we'll have enough time in the end to also discuss Q&As around anything which maybe was a bit overwhelming now with the whole description of the context. So our GRACE project, Eric already mentioned the name. It's gender aspects in rehabilitation of persons with amputation in conflict-affected environments. I would have loved to study all the questions I have, but I also learned that grants that have too many aspects are rejected. So we have kept it very neat and small now. And it's a big multilateral research with a lot of project partners. The money comes from the Swedish Research Council, and the main, so the PI, which is my doctoral supervisor, is from Linköping University. And here's the setup. So we have 3 research aims: to understand sex differences in demographic factors and clinical characteristics among persons with amputations attending rehabilitation. The second aim is to understand perspective of persons who have and have not attended rehabilitation about access, acceptability, and perceptions of rehabilitation. So asking the affected persons themselves. And the third aim is the perspective of health workers and of community leaders, so the decision makers, on how gender aspects impact access to services, service delivery, and health outcomes. These are the 3 work packages, and we are currently in work package 2. Work package 1 is finished. Remember, we said persons with amputations were the largest group of our first study on the big overview. And so this population is the focus of our GRACE project. And here's the study that looked more in depth into this group. We included countries, the 5 countries with the highest numbers of persons with amputations in the database, and the sex distribution was 85% men. Now, it was not possible to make statements on access barriers for women, as we did not have reliable sex disaggregated data on amputation incidents in countries of war. The existing data from amputation incidents in low-middle income settings, mainly from diabetes and accidents, cannot be compared to countries that have a massive landmine contamination or an ongoing war. Now, we analyzed a few aspects with regards to gender. For instance, when looking at living environment, it turned out that the proportion of attending women is significantly higher when they live in urban compared to rural settings. This was data that was not fully complete because it was not obligatory, and it's self-defined rural-urban. But it was a very interesting finding. We cannot explain if this is reflecting the real prevalence and the real disease patterns, or if it's related to access. Transport could be an issue for rural women, cultural traditions. Now, also beyond gender, this study provided some relevant indicators for broken health systems, or how conflict impacts health systems and population and individual health. We had a very detailed look at amputation causes and other clinical data, amputation combinations and levels. And we see here, for instance, that the proportions of traumatic versus non-traumatic was reversed when compared to high-income settings. So in high-income settings, you have about 2/3, 3/4 are non-traumatic, and here it's the other way around. But still, we have almost 25% of non-traumatic amputation in conflict. And this is looking back, so this is retrospective data. And this is also very interesting because it shows that amputation is really barely, diabetes is barely managed. Now on these graphs, you also see the traumatic and the non-traumatic groups. The first and the third block show age at amputation. And they show that average age is very young for traumatic amputations. And though older, it's still young for non-traumatic amputations when compared to high-income settings, where the average age for non-traumatic is over 65. Here we have just around 45 years of age. And we also looked at the delay between the incident and the start of rehabilitation, which is shown here in the second and in the last box. We see a considerable time lag. So time lag, on average, it's 8 years for traumatic and 3 years for non-traumatic amputations. And what does that show us? These figures indicate the mismatch of needs and resources. What happens to someone with an amputation who has to wait for years until they get prosthetic fitting? What happens on the physiological, on the psychological side? What happens to their ability to make a living? The shortage of rehabilitation services has a huge impact on society. And not only do we see indicators for lacking rehabilitation services, we also see the signs of broken health systems in general, where relatively young people acquire amputations that are caused by non-traumatic conditions, in most cases NCDs, that are preventable. The costs for care and dropout from a productive, autonomous life can quickly become overwhelming if health systems fail in proper NCD management. So this is kind of closing the circle of our excursion to rehabilitation in conflict-affected contexts. Research that unveils indicators of fragile health systems and underpins what is very well known in the humanitarian world, but not in the scientific world. And so our next steps will be to investigate the gender question, knowing that women and girls with disabilities in conflict count among the most vulnerable people in this world. And here's where this year we are entering the second phase with on-site research that's called community-based participatory research in 2 countries, Cambodia and Ethiopia, and that will include focus groups and interviews with persons with amputations. And then, as I said, in next year in 23, the same with the rehabilitation workers and community leaders. So I would like to thank all these people listed here. First of all, Unisanté, who offers me the post, and he supports the post and support in this research, and all my co-researchers. And now we have enough time for your questions and answers. And I'm looking forward to the discussion. Thank you very much.
Thanks, Nell. That was quite impressive, I must say, and I think it's quite sobering to see. I mean, what kind of problems are prevalent and urgent in settings other than the one we know here in Switzerland or in similar high-income countries. I have noted quite a few words for questions, but I will see first whether there is. Muriel, you have your hand raised, so go ahead for the first question.
Yeah. Thank you, Cornelia, for this excellent presentation. And as you say, Eric is brings us back to to our reality. And sometimes we complain about our situation, and then we can see that we should maybe not complain as much as we do sometimes. I have a question regarding database and management and access and privacy issues. How is the data managed? Where is it located? And how did you deal with ethical aspects? I mean, I guess for such a project and international component data from many different countries, how do you deal with those issues of collecting the data, managing the data, and also storing, securing? How do you deal with that?
Yeah, thank you for the question. That's indeed very important because we also are dealing with Icsc connected data, and you may know that they are very, very protective because it's sensitive data, especially when it relates to armed conflict and very political situations. So the database that is donated to the centers, very few are Icsc owned, where the data is owned by the Icsc. In most cases, it's partner centers. The database is donated to them, and then what we have analyzed is this routinely collected data. So we didn't need individual patient consent because it's the registry sort of, and when someone enters rehabilitation, they agree to this data being collected. And when I accessed the data, I also had a shared agreement and a consent with each of the centers who on their side anonymized the data. So they basically took out all the names and the addresses of people. However, the data are still persons are still identifiable, because if you have a young male 25-year-old with this amputation pattern in a country, I mean, you can just so easily identify people, and that's why we cannot publish anywhere the raw data. So the raw data are with me under password protection, and we have data sharing agreements with the participating institutions. And we have ethical clearance from the Ethical Committee of the Canton of Geneva, because it is this retrospective data. And for the focus groups, it was the same. The participants all signed an informed consent, and it was within a workshop. And also for that, we achieved ethical exemption from the Canton of Geneva. Yeah.
Thank you.
I forgot to say, if you want to ask a question in the chat, feel free, and also if you want to ask a question not in English but any other language we can master. Nell, when you talked around access to the services, but also actually the access that you need to people with amputation for your research. I mean, I was wondering, how is it possible in these difficult environments to access people, and in particular women, who cannot make it easily to rehab services? Because if your starting point is where there is a rehab center, you can only talk and get information from those who can make it there, but not those that might be really interesting for you, those who have massive barriers to go there, be it by geography or by culture and so on. So what are possibilities or strategies to access those people? Is it possible for example, to go through basic community health services and identify people with amputation and then go and see them or obtain some information why they cannot make it to the next rehab center and just have basic medical care if needed by let's say, a community nurse or so?
Yeah, I mean, that's also very, thank you. That's also a good question, because it's hard to imagine if you don't know these settings. And indeed, it is actually, it's always the two aspects. It's access for the population, it's access to the population. And there's always, in a war, you always have a problem with checkpoints and with certain groups being shut off, etc. So really both to and for the population. Now, very generally, I can say there's a big advantage of the Red Cross system, because in every country in the world you have a National Red Cross Society, and they are actually the community workers. They know the community, and if they are briefed by the rehabilitation program, they are the ones who reach out and spread the word. And then obviously in such settings where the whole infrastructure is broken down, the informal sector of knowing where services are available is very, very strong. So that is one thing. And the other thing is also, if you work within the Icsc with all the different projects they have, we would work very closely with the so-called protection delegates, those who cover a certain zone, and they negotiate with the armed groups who spread the word. And then also a big source for us is the so-called Economic Security Department, because they do household surveys, and they also so they're basically briefed by us. They proactively look for persons with disabilities. So that is the identification part. And then the other part is, how do these people reach us? So we have the Icsc, you may know this, they even have planes where they bring plane loads of persons with amputation to rehab services, and then all kinds of facilitating transport, paying transport, also trying to identify particularly vulnerable groups, women-headed households, etc. And this is how we try. The program tries to reach people. But then again, coming to my particular concern, we always go with our glasses or our filter. And if a program is very much directed at adult males, we cannot guarantee that we'll really find them all systematically. So I assume that there was a filter that identified particular persons, and that's why we want to talk to the people on the ground to know what's wrong with this low representation of females. Yeah.
You didn't mention, when you talked about the culture. So in that first part, you didn't mention adherence. So is that sort of, I mean, that's closely linked to cultural factors. And I mean, we all know how difficult it is to maintain adherence, especially if it's for long-term care in a stable setting. So is there a risk that sort of, with the scarce resources that are available, rehab services are set up, but then it's on the let's say on the personal side of those who should benefit from it, that they, for whatever reason, cannot maintain the adherence. They might give up on their fate or be whatever sort of fatalist, and not sort of be able to stick to a rehab program, even if they would benefit from it. So how strong is that factor? Or is it even stronger than in a stable environment like, let's say, ours, to focus on improving or enhancing adherence in beneficiaries of rehab?
I mean, it is certainly an issue, but there are measures that are controlling for it. And first of all, is that the rehab centers are usually in urban settings, and the rehab is inpatient. So the rehab centers have dormitories, and the entire phase of the fitting a prosthesis is whilst the person sleep and eat at the center, and they are only released when everything is when they check out, when everything's finished. But then the adherence during that phase is more understanding what rehabilitation is about, and that it means active involvement, that it's not swallowing a pill, but really like exercising. That is one thing, but the issue is actually the follow-up. And in amputation, they would need replacement, or if they have a wound on the stump, they would need to come for follow-up or repair. And another typical example is in clubfoot. The children get this serial casting, and there's a tight follow-up scheme, and that is tricky. So there are certain measures, and I remember I had that discussion with our colleagues from Afghanistan, who have created a system of sanctions to make people understand, if you tell you come this month, this day, and if you don't show up, then you're not going to get a further treatment. And then they also have established a system of calling and text messaging. And apparently with this tiny punishment, the system works much better. So they had a real improvement. But it actually means they're really allocating one human resource in chasing after people, because adherence is an issue. Yeah.
Muriel, your hand is up.
Yeah, I had another question while listening to you. Do you have information on the cost and on the, do those people who attend those rehabilitation centers have to pay out of their pocket? Or I guess the situation likely differs across countries, that maybe in some countries it's covered, by the health insurance of the country, if any is available. But I guess another barrier could be financial. Is it correct?
Yes, absolutely. And if the services are Icsc supported, the whole rehabilitation is free, is covered by the ICRC. It is not the only thing, because I remember there was a big study in Myanmar where they investigated exactly that. And actually, you have certain communities, like in Africa, you have this whole web of family support, which is less the case in East Asia. And if a head of family in East Asia has an amputation, the entire family falls into poverty. And that starts before rehabilitation. So actually the issue, the financial issue it starts much earlier than the rehabilitation starts. And then these people are minimum 2 weeks, and with the transport and everything, they're minimum 3 weeks outside their family. So who looks after their children, who supports for a living, and I think in some projects this is compensated for, and in others not. But the services as such, they are free. And actually my 2 pennies on that is that this is not always the best idea. I think there was that's not published data, that's anecdotal data, but I think they compared where persons had to contribute a little bit to their prosthesis to those where it was entirely free, and the replacement rate was basically the care someone brought against their prosthesis was higher when they had to pay. And the payment doesn't need to be money. I know that some services, they ask from patients to help in the kitchen, or to do gardening and things like that, or to contribute in some ways. So I would actually support that, because it really adds to the value of rehabilitation for these people in the range of what they can give. But the policy of the ICRC is that services are free. Yeah.
I think what you just said before in terms of rehabilitation being mostly in hospital, I mean, that's very different from here, where you would try to have people in out of hospital ambulatory care as early as possible. But of course, I mean, when people come from a distant region and so on, that's just not possible. But then it also means that they have probably more opportunity cost to really go there and stay, for example, for the fitting of prostheses, because even though they might have an amputation, they might still have a role in their family. So or whatever else. So if they go, let's say, a few years after whatever trauma with an amputation for rehab and prosthesis, they might miss out on whatever roles they have, taking care of children, elderly, nevertheless having a job and so on. So is that something which needs to be taken into account, or maybe that there would need to be some support actually for them to be able to leave their roles and go for rehabilitation for a few weeks or however long it takes?
Yes, I mean, first of all, they're not in a hospital. It's a rehab center, and they are in a dormitory, so they don't have any during the day. If they don't have services, they can go out and do whatever they want. But they it is purely for infrastructural reasons. So a nice example is Gaza. Gaza almost has sex equality in rehab attendees, because I mean, Gaza is basically the most enclosed environment you could study, and there's public transport everywhere. Obviously, people don't stay in a dorm. They come to rehab, and during the day they do their thing. But or also in Juba, in the capital of South Sudan, if someone with an amputation from Juba goes to rehab, he can go there with a taxi or however he reaches. But most come by plane from the very remote battle areas. And then, indeed, as I also said before, discussing Muriel's question, these weeks of dropout of family and work can be an issue. Some projects cater for that, and again, it is very cultural. So very, very crudely said, African societies are more flexible because someone replaces someone and the family is always looked after. In some Asian contexts, which I know less because I work mainly in Africa, it's less the case. So the projects they try to cater for that in one way or the other, and to replace. I mean, they can't replace drop out of work, but they can give some incentives to the family, etc. Yeah.
Sure. I'm just looking at the chat or whether there's any other hand raised. If I may, I ask you a last question, unless there are other questions coming up. I mean, I was wondering in terms of the when you showed that violin plot, you know, and you said it's also younger people who could still be part of the workforce, but they wait years to get rehab and maybe prosthesis and so on. I mean, would it be possible? I mean, and at the same time, it's difficult to get sustainable funding for these services, but even for research like the one you are doing right now. I mean, would it be possible to sort of to somehow focus on the economic case and make that more attractive for example, governments, but also international organizations? And I think that has been tried in other contexts as well. So not only sort of calling for, let's say, the humanitarian side, sort of there is a vulnerable population and we need to help them, but also that it is economically, it is wise to focus on those people because they might need less care and that might cost less in the social system. and they could positively contribute because they might have, before their injury, they might have received education, and they could positively contribute to the economy or to society more broadly, and sort of focus on that and make the case with governments that it's worthwhile also economically to invest in rehab. I mean, of course, that's only possible where in a region or a country where there is a government that has some resources, or where you can go and it's safe enough.
Yes, absolutely, Eric. And I mean, to be very honest, this is the only thing that counts. Only if you can show what gets lost in terms of money and what a country loses on workforce, then you can convince decision makers. So there is really a huge need for cost, and not only cost effectiveness, but really drop out on workforce. What does it mean for an economy? But studies are rare. I mean, I know there's a number of studies on clubfoot which shows cost effectiveness, and clubfoot is fantastic because it's let's say rehabilitation is relatively simple, straightforward, and you can prevent a completely disabling condition. People with clubfoot, I mean, I think it's difficult to imagine for us, but they would usually they walk on the backs of their feet and they are totally disabled, and if you detect them at young age, you can easily, with serial casting and with one tenotomy, you can prevent a disability. So because this is so well defined, there are cost effectiveness studies. Not in amputation, I haven't seen, and prosthetic fitting is extremely expensive, and prostheses need replacement every number of years. So some health systems have no money whatsoever, and also to form a workforce who can fabricate a tailor-made prosthesis and adjust it. Also investing in creating that workforce, that is actually the big issue for the coming years, in my view, and it can only be proven with economic studies and cost effectiveness studies, but this is lacking.
It's somehow sad that actually you need to talk about money and not about sort of the human side and the needs and what it means for people to live with a disability that could possibly be treated. But I mean, it could also be, I mean, if it's not possible in those contexts to come up with population-based studies, it could be compelling case studies, you know, of a small group or even individuals, and showing what they, with some investment into their rehabilitation, what they could sort of bring back to their country and their society later on. And
yeah,
and that might be even easier, sort of to build up such case studies than collecting, as you have said before, data on a larger scale, or longitudinal data in settings where that is really difficult. Just checking. I don't see any other question. I don't see anything in the chat, and time is almost up. So. I would say many thanks, Nell, for giving us a glimpse of that work, and I think we will be interested and curious to see how your research project evolves, and I hope there will be another opportunity in some time when some from the second and third part of your project, some data are collected to present this in this or another format at Unisanté. So with that, thanks very much, and thanks to everybody for attending, and have a good rest of the day and week.
Yes, thank you all from my side very much, and thanks again for Unisanté to let me do this exotic research, and looking forward to further exchanges. Thanks.
Thank you. Bye.
Bye-bye.
Bye.